Prof, obesity is often called an epidemic. From your opinion as a surgeon, di pendapat Prof, how bad is the situation of obesity in Malaysia?
Okay, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Okay, thank you for inviting me for this podcast. So basically, obesity is a global pandemic, and it's not just now called obesity; it's called diabesity because it's always synonymous dengan somebody who has obesity will have diabetes as well, type 2 diabetes. So in Malaysia, the situation is very critical because based on the National Health Mobility Survey 2023, the incidence of obesity has increased. Malaysia is one of the fattest nations in the world, okay? And the rate of obesity is increasing at an alarming rate in Malaysia. So if kita tengok the rate back in 2019, National Health and Mobility Survey, the incidence of obesity is around 51%. Okay, this is a combination between obesity and overweight patients. But the more latest National Health Mobility Survey in 2022 or 2023 showed that the incidence of obesity has increased from where it was before to 54%.
Okay.
So a combination between obesity and overweight. So it's very alarming.
Okay.
And what is also much more worrying is because the incidence of diabetes is also very high in this country, around 15 to 16%. So nearly 1 in 5 of our population has type 2 diabetes. And this is normally parallel to the incremental rate of rising of obesity as well. And the rate of metabolic syndrome, which is a combination between obesity, cholesterol problems, hypertension, and diabetes, is also increasing. So imagine the latest survey showed kita punya rate of hypertension is 29% in this country, very high. And cholesterol is about 33%. So taking into account of all, you can see how serious the situation is.
Yep. So we are the highest obesity population in Malaysia.
We're talking about if in Southeast Asia, we definitely is the number one leader in obesity, which is nothing to be proud of course.
Exactly.
Yeah.
Okay, so from your experience, what contribute to that increasing in numbers?
Okay, so first is very important for everyone or listeners to know what is the definition of obesity.
Yep.
So definition of obesity is where you have excessive unwanted fat. Simple. Okay, so our body mass has 4 main components, basically bone, water, muscle, and fat.
Okay.
So it's the fat, excess fat is the issue because that will over time, especially where you have accumulation of fat around the abdomen, which is called central obesity or visceral fat, this will start attracting a lot of metabolic issues like diabetes, high blood pressure, fatty liver, hypercholesterolemia. Because of this, it increases the risk and complication over time. WHO has classified obesity not as a lifestyle problem anymore. It is a disease.
I see.
Okay, so when we treat obesity, we are actually treating disease, but not only just the disease, it's the mother of all disease because it attracts hundreds of medical problems as a result of obesity. And this is why it's very important that we need to eradicate obesity as much as possible. And going back to your question just now, what actually causes obesity is very multifactorial, but the one simple principle of how fat is accumulated in our body is basically when we have excessive calorie, which we don't burn. So where does calorie comes from? Which is carbo.
Yep.
So it comes externally. The body cannot produce carbo, but the carbo in the body which is not burned is stored in our body as fat in the adipocyte area and also in the visceral side. Whereas fat also is stored in our liver in the form of glycogen. So a combination of this, and this is why soon fatty liver is going to be the number one cause of liver cirrhosis, and we are seeing now. And I have operated on patients who purely have obesity and has developed liver fibrosis and eventually becomes liver cirrhosis.
Liver cirrhosis.
Yes.
You mentioned earlier that WHO reclassified obesity as no longer a lifestyle diseases.
Correct.
Any reason for this?
Because it's pretty obvious that if you look at patients with obesity, even though they look well.
Yeah, they look well.
Okay, but if you do all these investigative tests, and I do all these things because, for example, patient who's going to undergo bariatric surgery, we do an extensive preoperative workup. And from the initial history when we saw the patient in clinic, they don't, tell us of any medical issues. But after they gone through a complete series of tests, then everything is revealed.
Yeah.
They've got new onset diabetes with an HB of A1C of unrecognizably 11. So it's very dangerous. It's just waiting to explode at some point. They've got ischemic heart problems. They've got fatty liver. They've got OSA. They've got joint problems. So it's inevitable that even though they look well and they don't, and the history itself originally they don't have any medical problems, they definitely have a medical problem, at least one. Fatty liver guaranteed in all obese patients.
Okay, when we talk about a staggering increase in percentage of obesity in Malaysia back from the year of, just mentioned just now, Prof, 2019 until 2023, how many percentages now, Prof, you mentioned?
So basically from around 51 going up to 54. But in 2019, half of the nation's population is either obese or overweight already. And there has been many active ways the government are trying to, make sure that the general community is well educated with regards to obesity and acknowledge the dangers of obesity and how we can resolve the issue of obesity. And yet, subsequently from 2019. Up to 2022, the rate is increasing.
Yeah.
So at the moment, we are not winning.
Was
Obviously.
that something surprising? Because, looking at the fact that Malaysian food, it's really, I would say, sedap lah.
Yeah.
If you for this to say no for that, is it purely the food problem or our lifestyle?
Like I said, it's multifactorial. And when we talk about obesity, you have the genetic component, the epigenetic component. That means the gene, with the help of the environment, help the obesity rate to accelerate in an individual. And of course, external component, which is the main contributor, which is diet and exercise and sedentary lifestyle. And based on the NHMS Mobility Survey 2019, they identified that 1/4 of the nation population has never had any experience or inclination to exercise. They just live their life, in a sedentary lifestyle. So obviously, this definitely contribute. Plus, our country is just rich with the different types of food. Plus, and it's cheap as well. So a combination of this, and of course the rise of numerous processed food.
Yep.
This is one of the primary contributor. Most people say, obesity ni run in a family lah, doctor, because all my family is obese. Actually, it's not the family. It's not hereditary, to be honest. It doesn't run in the family. It's just the family doesn't run. Yeah, basically, it's just a culture within that family that they like to eat. So obviously, everybody eats. So that's the issue, because the chance of we identify a patient purely due to genetic problems such as Prader-Willi syndrome, such as leptin deficiency syndrome, it is very, very rare. And most of these patients has manifestation of mental retardation as well. And most of these patients normally don't live long. Normally they probably live up to the to age of 30 years old. Because most of the time they die because of the obesity has complicated by diabetes, cholesterol problems. So they die with heart issues, they die because of stroke. I've operated on 2 patients, but that is just the tip of the iceberg in comparison to the normal general obese patient, which I operated. And I've operated more than 4,000 bariatric surgery during my experience as a surgeon.
I like the point, Prof, yang you mentioned about kalau let's say mak ayah dia gemuk, most of the time anak-anak dia akan, I notice memang betul, anak dia akan gemuk juga. Like you said, there's no genetic inheritance in terms of obesity. Yes. But is it a mental issue? Is it an addiction issues or?
Okay, so basically there has been a study which has been published that showed that a baby born in an obese mother will be an obese baby.
Okay.
I mean a big baby. But the same mother who lost weight and subsequently is pregnant again, the baby has normal weight. Okay?
That's interesting.
Yeah. So, but then why would the mum be obese? Because there's the same person but 2 different weight at some point. It cannot be genetic. It's just purely environment or external factor, which is food. So I think the epigenetic component is probably more overwhelmingly controls the situation rather than pure genetic. So that means the food that you take, process in the body with the help of certain genes that may help. Maybe they have leptin gene deficiency, so it accelerates the process of obesity. But when they eat less, they lose weight, it does not actually transfer to the baby itself. So I think the epigenetic component is far more important than purely genetic. But definitely, no doubt, if you basically start eating 4 plates of rice per meal every day, and I can bet you in 6 months you'll be obese. Easy. It's just purely food and sedentary lifestyle. So basically, the lesson is you just need to eat food in moderation and try to cut down a carbo, basically. And complex carbohydrate is just like rice, bread. Spaghetti, all these are high and rich in carbo. There's no issue if you eat more. You just need to burn more.
Yep.
So like all these soccer players, Premier League players, they eat a lot of like pasta and all the stuff because they provide carbos. So that's fine because they need
the
that
carbo.
extra energy, but it immediately get burned as they exercise. So we're talking about in a normal person who has not much time to exercise. Plus nowadays the working hours is longer. By the time they go home, they get tired. So it's very difficult to push and motivate yourself to exercise. So the only way is you have to cut the calorie intake to create a calorie deficit in order for you to lose weight. Yeah, because this is why when people ask, how can we lose weight? The principle of weight loss is calorie deficit. So that means cut down your source of calorie primarily, which is carbo. So you can enjoy fat, fiber, protein, no problem. Eat small and frequent. And also you have to exercise. But how do we focus in terms of percentage? 2%, 20% of basically 20% of exercise and 80% of food, basically.
Okay, Prof. Have you noticed from your experience, is there any difference between financial status of particular family in pertaining to obesity?
In the context of Malaysia, no.
Oh.
Not really.
Not really?
Oh, not really.
Meaning whether you are B40, M40 or T20, the rate of obesity doesn't really affect it?
Yeah, because I see obese patient in the public side and I see patient in the private side. In terms of the numbers is pretty similar.
Oh.
The number of patients that require bariatric surgery, for example, in UKM, the waiting list for bariatric surgery alone is more than a year or two.
Oh my.
So imagine, these are the B40s patient who most of the treatment is done in the public side.
Yep.
And we also have a patient that I see in the private side. And again, the only difference is the private side, it can be done faster. But if you're talking about the percentage, it's pretty comparable. I think it's obesity, because of its overwhelming percentage that's affecting the whole population of the country, not only the country or the world, you would expect that it is going to affect every layer of the society.
Because the reason I ask, because I notice the food, healthy food is expensive. The one in processed food, that one is the one actually affordable. And apparently, looking at the way that people are doing juggling works, from multiple of works, and then they will grab whatever possible untuk makan.
Yeah.
And this is, I thought, directly contributing to obesity.
Yeah.
But from your experience, there's not much of difference.
You see, as I said, the principle of weight loss, or you want to maintain the weight, you must first is make sure that if you're overweight or obese, you have to go back to normal weight.
Yep.
And from there, you try to sustain that weight loss. But if you're obese, you need to lose weight. You must have calorie deficit.
Yeah.
Okay. It does not matter what you eat. The problem is you have to question yourself why, from a normal weight in your teenage years, active playing sports for the school, and suddenly at the age of 30, after you got married, your weight goes up. So it doesn't make sense, right? Yeah. So if you dig into the history, the story is 100%, I tell you, because I love food. Yeah. And no point of asking what type of food. You know that why it builds up all these fat in your body is because most of these contain a lot of sugar.
Yep.
And sugar comes in complex sugar, which is like rice, like bread, and simple sugars like processed sugar where we put in our tea or coffee. So it's the sweets is the issue. So basically, for me, what you eat and the amount you eat and how frequent you eat, and eventually develop a culture of eating and sedentary lifestyle is the main issue. It's nothing to do with levels of society, because the more expensive is supposed to be a healthy food is not that tasty, correct?
Yep.
Yeah, so if you have money, of course you want to go for more tasty food.
Yep.
Yeah, why would you want to go for a salad? So the point is, there's nothing wrong with eating whatever you want to eat, but eat in moderation.
Yep.
Eat in moderation. But if you come to the point where the past 30 years you have enjoyed food, I think it's time that you have to take care of your health, and now it's time for you to be more specific on what you eat and try and calorie count. Because in terms of more objective and scientific way to lose weight is simple. 1 kilo of fat equals to 7,700 kilocalorie.
1 kilo of fat equals to 7,700 kilocalorie.
Yeah.
Okay.
So if you want to lose basically 1 kilo a week, then 7,700 kilocalorie divided by 7 days equals to 1,100 kilocalorie. So you stick to that 1,100 kilocalorie
per day.
Every day, you will lose 1 kilo. But the problem is that alone is inadequate because there is no consistency. A lot of patients ask me, "Doktor, kenapa bila saya diet? Doktor, saya diet. Saya serius diet. Memang tak makan banyak, cut down sugar, tapi berat tak turun. Hari Minggu you buat apa? Hari Minggu saja saya break, doktor. Saya rasa saya deserve makan lebih sikit." Yes, that's the reason why you don't lose weight.
Cheat day.
Yeah, the cheat day. There is no consistency. So if you want to lose weight, you need to at least be consistent of 1,100 kilocalorie, count every day for the next 4 months, then you can see the difference.
Okay.
And the other issue is motivation. How do you get motivation? Motivation is something that something that you're looking forward to. If something doesn't actually stimulate your mind, how are you going to get motivated? So basically, in order to motivate you to lose weight, there must be a sign that you're losing weight.
Yep.
So if you're losing like 1 kilo and your weight is 140, how are you going to get motivated from there? But if you lose 20 kilos or 30 kilos from an original weight of 140, yeah, of course, it will motivate people. And this is where other modalities help. If you dah cuba diet, exercise dah tak jadi. So it's not a shortcut. It's a clever way to save your life because you have no other option. Berat 150 kilo, dah ada diabetes, diet dah tak jadi more than 6 bulan. Okay? There is help in this country, and living now is much better than living like 30, 40 years ago. Sebab at that point, there's no technology.
Yep.
Now, with the technology, we have options of medication, and more new drugs are coming. Okay, we have intragastric balloon, we have endoscopic. By endoscopy, we can try and make the stomach small and placate it. And of course, the ultimate bariatric surgery that will give the most and confer the most weight loss. So there's help. So the majority of people just don't know where to find help. But nowadays, we have more and more places and hospital and center that can help. So we don't discriminate whether you have money or not. We are here to help. So if you don't have any money to fund for the treatment, which can save your life, we will help you. So there's always a public sector that can help. Public hospital, UKM, we are the center for Hospital Chancellor Tuanku Mukhris, is a center for bariatric and metabolic surgery. So we have dealt with beribu-ribu patient already, with a good success rate, a minimal risk complication. Because why? As in comparison to somebody yang nak buat operation biasa berbanding dengan patient nak buat bariatric surgery, I can't think of any other operation where we extensively investigate all these patients pre-operatively to make sure that they are suitable for the operation and safe for this operation.
So we talk about option or modality. You mentioned earlier medication. Before medication, is there anything else that you do? I mean, you consult the patient?
Of course. So the normal situation is a patient has obesity. Sudah cuba diet, exercise, tak jadi. Okay. And then they come and see us. So what we do is we take a full history, full examination, and then we counsel them with the option. So it depends on berapa banyak mereka nak hilang berat badan lah.
Okay.
So if they accept dalam 5 ke 10% of their current weight they want to lose, then medication would be the more plausible or feasible option. If they want more, then the next step would be intragastric balloon, which confer around 10 to 15% of their total body weight loss. If that doesn't interest them and they feel that, that's too small, doctor, saya nak lebih lagi, then you can go for endoscopic treatment, but we don't have that facility available yet, and it's a bit more expensive because of the equipment that we use. Hence, the next step above that would be bariatric surgery, which confer around 30 to 40%. And bariatric surgery pun ada banyak jenis. There are many different types of bariatric operation. There are nearly more than 10 to 15 types of operation that we have nowadays. And bukan satu operation untuk semua orang yang ada masalah obesity. It's one operation tailored to a specific problem of the patient yang suffering from obesity tu. So this is why you should take advantage. Jangan and leave it to fate that beginilah masalah saya dan biarlah saya berat 160 kilo, tak apalah saya 25 tahun. I think ini Allah nak bagi cabaran. Of course Allah bagi cabaran, tapi Allah juga nak suruh you berusaha. Yeah. And jika ada rawatan, then you should go for it. Sama juga susah lah nak semayang, tapi Allah bagi 2 km ada masjid. Tak ada, there's no excuse. There's no excuse. Health is the number one thing. Without health, if you don't look after your health, then there's no you. And there's no you can't find money to work. You know, you can't find work for obviously to support your family. You cannot enjoy life. You cannot raise your children. You cannot motivate other people. So this is just like a vicious cycle.
Yep. Yep. When you mention about the effect of obesity towards the patient and the family, what kind of complication are you talking about from obesity per se? You mentioned earlier about diabetes, hypertension, anything that are specific?
So the top 10 of the normal association of medical problem associated with obesity, pertama, diabetes or insulin resistant. Number 2 is cholesterol. Number 3 is hypertension. Number 4 is fatty liver. Number 5 is obstructive sleep apnea. Berdekur tengah malam, you stop breathing at night. Okay. Number 6 is joint problems. Back pain, chronic lower limb joint problem. Infertility is very common. Ada 13 kanser yang meningkat jika you ada masalah obesity. And then incontinence, stress incontinence, bila batuk senang kencing, especially in female. Okay. And of course breathing issues, restrictive lung issues, so you tak boleh inspire lebih sebab restriction of your weight of your thoracic cage, and the diaphragm is limited. So it result in restrictive but also obstructive because of the OSA. So ada banyak lagi, the small ones. Yeah. So name it, you have it.
Okay, so just walk me through. Let's say I'm obese. I tried diet, I tried exercise. My weight is still, let's say I give you an example, 150. So what should I do? Should I straight away seek treatment, or what's the process usually?
So in this case, you come to the point of 150 kilos.
Yep.
And I'm pretty sure when you are at a younger age, you were around 70, 80. So you can see a rise of 70 kilos over time. And common sense says it's unlikely that you're going to lose weight. More likely the weight is going to continue to go up. And the more weight you have, the more mechanical burden to your body, and the more restricted your mobility is, then definitely you're going to lose out because you won't be able to exercise, and the likelihood of the weight will going to pile up. Okay. Diet and exercise, if you just lose 1 or 2 kilos, it's meaningless. Meaningless. You hilang 1-2 kilo, you berat you 150 kilo. Means nothing. Yeah.
It could be water weight, right?
For the amount of effort you put, and untuk exercise pun, plus of course by exercise, the stomach is still there. In the ghrelin in the stomach still produce the hormone which increase the appetite. So most likely you will cheat. So this is why you're not going to lose weight. So this is where you come to the point where you have to surrender and accept that natural way is not going to work. It needs other form of treatment. And now I hear about hospital that to provide facility to help obese patient. So you should take advantage of that and come and seek treatment at this hospital. So one of the example, Hospital Chancellor Tuanku Mukhris, we can help you.
So how do I, usually I'll just go to the hospital and then say that I want treatment for my obesity. Is that the way?
So basically, you can either walk in, but most of the patients go to klinik kesihatan atau GPs, and they will do a referral letter. Because it's a tertiary hospital, it needs a referral letter. So you take the referral letter and bring it to klinik surgery, the Hospital Chancellor Tuanku Mukhris, HUKM, nama-namanya, and they will make an appointment lah. From there, once you have an appointment, come and see a team of doctors, and normally if they agreeable to undergo a specific treatment, in this case say bariatric surgery, then we will admit them for extensive pre-operative checkup, and this include blood tests, ECG, chest X-ray, ultrasound scan, endoscopy. Refer to cardiologist and they do at least a minimum of echocardiogram. Refer to respiratory, they will do a lung function test, including sleep study to assess the presence of severe obstructive sleep apnea. Sebab kalau dia ada severe OSA seperti AHI of more than 30, then we would recommend them to be on CPAP machine, continuous pressure airway pressure. And then we refer to endocrinologist. If they have diabetes, then we will start on medication for diabetes, but not only medication for diabetes, but medication that can help you lose weight on top of controlling the diabetes. Seperti Saxenda, seperti Ozempic, seperti Trulicity, and Rybelsus in tablet form. So ada banyak jenis. So and of course we refer to physiotherapists to show how to exercise, and the most important thing is the dietitian. The dietitian will start patient on very low calorie, 800 kilocalorie on a liquid diet 2 weeks before bariatric surgery in order to shrink the fatty liver, reduce the visceral fat to give more space and menyenangkan operation. And we know lagi senang operation, lagi less complicated the operation is. Less complicated, then the chance of complication is less. So this is very important. Also, why we put them on very low calorie diet is to prove that they're disciplined enough, follow what the dietitian recommends. They lose about 2-3 kilos. Kita bukan aim untuk hilang banyak sangat, but at least they lose 2-3 kilos just to show that they're disciplined. Because people who lose weight before the operation, the success rate of losing more and sustainability of that weight loss after the operation is greater.
Wow.
This is evidence based. Okay. And finally, just nak mirror image, because 2 minggu pertama sebelum operation you ambil susu. 2 minggu pertama selepas operation, you ambil susu juga, liquid diet, followed by another 2 weeks of porridge, another 2 weeks of soft diet, and after that normal diet.
Okay, but when you assess the particular patient, do you have a criteria like, okay, this patient fit for bariatric or for intervention, or this patient is more towards medical therapy?
Okay, so the contraindication for bariatric surgery, pertama, if the patient is not fit for general anesthesia, full stop, because the operation is done under general anesthesia. Nombor dua, if the patient has significant psychological or psychiatric disorder, seperti severe manic depression, severe psychosis, or severe depression. Number three is if they have eating disorder, seperti bulimia, seperti anorexia nervosa. Number 4 is if the patient has coagulation disorder, that means darah dia cair, so we cannot do the operation.
Okay.
Number 5 is the patient is on coagulant atau antiplatelets yang mana tak boleh kita stop the ubat, so then we cannot do the operation. And if the patient had recent major acute cardiovascular events seperti major heart attack or major stroke, which we hope that stroke will recover, but more towards the heart attack. So if we're going to do the operation, at least after 1 year, because anything below will be high risk. But then all this decision is not only made by us, the surgeon, tetapi it is multidisciplinary. So if we have a complex case, we always discuss in a meeting among the specialists. Sama seperti tumor board meeting or MDT untuk cancer cases.
So meaning to say, patient boleh jump directly skipping the medical therapy terus ke surgery. They can do that?
Yeah, of course. Because macam saya kata tadi, medical therapy hanya confer kehilangan berat dalam 5 ke 10%. You 200 kilo, you bagi medical therapy, you dalam 20 kilo, you still ada 180 kilo. It doesn't make sense.
Yes.
Yeah. You're just wasting your time saja. Okay, and the problem with medication, of course it works while you're taking it, but when you stop, there's always the potential risk of rebound balik.
What's the science behind medication? I mean, how does it work in reducing obesity?
So there are many different types of medication. Normally we divide into 2 types, pills and injection form. So the pills ada banyak, antaranya Duramin, then we have Contrave, which basically function by blocking the brain side, which is the limbic system and the hypothalamus. Basically these are craving centers and appetite center and hunger center. So you block. So you don't feel any of this. So you eat less. Then we have the GLP-1 analog. So GLP-1 is a hormone that's actually naturally produced by the L cells in the distal ileum. And the function of GLP-1 is to block your appetite. Number 2 is slow down the gastric emptying to make you feel full longer, but also stimulate the beta cell in our pancreas to increase the insulin production, hence reverse insulin resistant state. So so these are the GLP-1s are the one that's a lot we talk. It's the most popular and the most talked about drugs nowadays. So the oral form is the Rybelsus. The injection form are examples seperti Saxenda, seperti Ozempic, seperti Trulicity, dulu ada Victoza. So what they find is at a lower dose it helps diabetes. At a higher dose they found out that it helps reduce weight.
Oh.
So the same drug, but they market into different brands. So contohnya Ozempic. Everybody sekarang ni tengah cari Ozempic.
Betul.
But the problem is it's the stock issue worldwide. So it's very difficult to get.
Is it over
because it was misused. So people who doesn't have obesity use it. People doesn't have diabetes try to use it just for the sake of trying to lose weight, even though their weight is normal already. So I think these people yang ada normal weight and still ambil ubat ni and trying to lose weight, I think they have psychological issues.
Like body dysmorphic.
100% they have psychological issues. Because if you have normal BMI, why on earth you want to lose weight lagi?
Yep.
And you will not lose weight anyway because the body has a set point and accept that this is the normal weight. Very difficult for you to lose weight. And number 3 is you are taking other people's opportunity to use that drug for proper treatment of diabetes and obesity. So I beg people yang ada normal weight, why? And I think it's very unfair if you take this medication just to maintain your weight and to lose weight, because by obesity guideline, I wrote part of the section of the latest obesity guideline which was introduced last year. It's the 2nd edition. In that obesity guideline kita dah clearly put criteria on who should get this type of treatment. So by definisi rawatan semua ni adalah untuk obesity. Bukan untuk normal weight. So I think it's very unfair for people yang ada normal weight or people yang BMI yang normal and still take this medication and trying to lose weight. You're not going to lose weight. It's meant for obesity. You have excessive fat, so that fat will be shed. So when you shed that fat, you lose weight. So memang kita guna untuk bantu orang masalah obesity dan ada masalah diabetes. So try not to abuse it and use it, and tak bagi peluang untuk orang yang betul-betul perlu. So now worldwide is running out of stock. So it's difficult to prescribe. Now of course with advancement of technology, the upcoming new drugs in the future seperti Mounjaro, which is available already in America or in Europe or in Middle East, but in Malaysia tak lagi. It's coming early next year. The Mounjaro is a dual receptor agonist, so it's not only GLP-1 but GIP. So supposed to be stronger and more effective in making people lose weight. And they are now doing studies looking at triple agonists or GLP-1 plus amylin untuk push more weight loss. But the only issue is adakah rakyat jelata biasa boleh dapat rawatan ini? Tidak semuanya sebab harganya mahal.
But it's interesting, Prof, because you say that medication can reduce up to certain percentage of weight, betul tak?
Yeah.
But while the pharmacology people are pushing the study for trial of all these agonists, antagonists, eventually at certain percentage you need surgery. It's a bit
of course. I mean, common sense always prevail. Okay, logic always say, why you want to operate if you have the opportunity to lose weight tanpa operation? Okay, so and if we're talking about 50% of our population that have obesity, that's more than 15 million. There are too many. If you're going to operate on everybody, thousands of years pun tak habis.
Betul. Betul.
Because we cannot just focus on obesity, rawatan obesity. We have cancer patient, we have other types of operation. So impossible. So of course, when we talk about people yang perlu rawatan obesity, hanya at the tip of the iceberg. At the base of the pyramid is always the more less invasive type. So definitely, no doubt, medication is one of the important treatment for weight loss, and apatah lagi the upcoming medication which can provide up to 20-25% of total body weight loss. What I'm trying to say is the availability of this drug is now is in a difficult situation because tak cukup stock.
Tak cukup
Because even the problem is it's being used off label. On label means manufacturer memang recommend for obesity. Off label, people yang tak obese ambil ubat ni. So kesian patient yang ada diabetes, patient tak boleh ni. Number 2 is accessibility to general public is always there. Cuma how can you get and use it? You have to have money because it's very expensive. I give you example. Contohnya the injectable form can take up to can cost between 700 to 1,000 per month. So that's very expensive. So if you are under treatment of KKM ke public side, of course it will not be in the hospital formulary because it's too expensive. So the patient has to pay out of their own pocket. So that is the issue. So ada rawatan yang berkesan, cuma you tak dapat sebab tak mampu nak bayar sebab mahal sangat. So then for me, if you cannot afford, then probably invest in a treadmill and exercise and just cut down. But the problem is susah lah dekat Malaysia. Memanglah seminggu disiplin, lepas tu tak disiplin. So in terms of hierarchy of treatment, in terms of pyramid, at the puncak would be surgery. At the base, which would incorporate a lot of more population, is at dekat base. And then kita naiklah satu-satu. So kalau ubat tak jadi, the other issue dengan ubat is side effects. Sebab the majority of GLP-1 side effect is pretty nausea, vomiting, cramp, bloating, diarrhea, constipation. And it's dose dependent. So sebab tu bila kita nak start, kita kena start at a lower dose and naik medium dose, higher dose, and then maintenance dose. So you cannot just ambil untuk 1 bulan because 1 bulan is just a starting dose. All these medication at least untuk ada impact kena 4 bulan or more. And that cost money. And some patient cannot tolerate the side effects. But they're still suffering from obesity. So then you're talking about the next step, which is intragastric balloon. So talking about intragastric balloon, how does it work? Its function is to take space in the stomach, so it restricts the amount of volume that you eat. So ada banyak jenis jenama of balloon. All except one type of balloon is swallowable. That means very simple. Tak ada injection, tak ada buat. Yang lain kena masuk melalui endoscopy. So that means kena bagi sedation, IV drip. Yang ni just telan pill.
It's a pill, Prof?
Yes. So kita banyak buat. So kalau nak tahu lebih, you can just always WhatsApp me or just message me. So the beauty of this balloon is very simple. The procedure takes about 8 minutes and it can confer around 10 to 15% of your total body weight lah. Weight loss. So contohnya 100 kilo, you can lose dalam 10 ke 15 kilo. So it's good enough because you're 15 kilos lighter. It helps you to exercise, motivate you. You look better anyway. And also the inches lost doubles the weight loss. So people will notice, wow, nampak different lah.
The inches lost doubles the weight loss. That's interesting.
Correct. Because you see, if you imagine 1 kilo of muscle besar jari saya. 1 kilo of fat besar iPad you. Okay. So this is where patient kata, doktor, so if we do bariatric surgery, patient kata, doktor, kenapa berat saya tak turun or static, tapi baju saya semakin longgar? Because you see, in terms of the mass, the fat takes more space. So if you lose 1/3 of that mass, but on the weighing scale 300 gram tak nampak, you dah shrink down already. So that's why I said, if you lose 1 kilo of fat, you probably shrink down double of that. So that's why nampak ni.
Yeah.
Yes.
Nampak kurus lah.
Yes. And also, it's important that, why when you diet, you should avoid carbo. Because carbo, which is glucose attracts, so 1 molecule of glucose will attract 3 molecule of water. So sebab itu, kalau contohnya satu hari minggu tu, dia enjoy, banyak pergi minum cendol, ABC, kuih muih. So hari Isnin dia kata, kenapa seluar saya ketat? To say that you fat is impossible to develop excessive fat. It's because of water retention. So this is why if you want to lose weight, cut down carbo. Short term, it will help inches loss. Long term, it will help fat loss. So that's what we want. Okay. So all these modality, which is balloon, akan membantu hilangkan dalam 10-15%, and it's done as a daycare, either swallowable balloon ataupun yang balloon masuk melalui endoscopy tu daycare saja kita buat. The typical side effect, of course, bila ada balloon dalam perut, perut need to accommodate and get used to the balloon. So awal-awal memang meragam sikit lah. So typical side effect seperti bloating, nausea, vomiting, cramp. So kita akan bagi ubat sebelum buat procedure, and kita akan bagi ubat beberapa hari selepas procedure tu.
How long will it take, the nausea, bloated?
So it depends on individual. Some tolerate well, so after 3-4 hari okay. Some takes up to 2 weeks to get better.
To accommodate the effect.
Yes, correct. So ada balloon yang stays in for 4 months. Yang the unique one is the swallowable one, where it stays for 4 months. After that dia akan auto deflate dan keluar bila pergi toilet.
Wow.
So one off procedure. So useful for those who live quite far and susah nak datang balik. Sebab kalau the one yang kita masukkan melalui endoscopy tu, stay longer in the stomach for 12 months maximum. But after that, kita kena scoop balik dan keluarkan balloon tu.
So the pill one will auto deflate by themselves?
The pill one?
The pill one?
Yes.
Wow.
Yeah. Kita dah buat, I dah buat beribu dah already. Yeah, banyak.
So how, you can decide the period of time lah, the balloon will be in your
Correct. Nak tengok video dah, tengok dalam my IG dengan TikTok @Dr Nik Rizakosai.
Okay, nanti kita boleh attach that in our.
And if you want to know more, you can DM dalam tu, senang. Yes.
Okay, and then this pill most of the time is 4 to 6 months, and then they auto deflate, and then will go out through the
the balloon. Yes. Yeah. So the issue with obat, balloon, it's considered in inverted commas temporary. Sebab bila you stop ubat, bila balloon dah tak ada, bergantung kepada patient tu. So tujuan utama is to help patient kena understand all these modality membantu hilang berat badan yang you nak. Sebab apa yang you nak dengan cara natural tak berjaya. Okay, so tak berjaya. So rawatan ini akan membantu, tetapi tidak ada jaminan di jangka masa lama yang berat you tak naik balik. So sebagai pengajaran, semasa you ambil ubat, semasa you ada balloon dalam perut, so you kena train. So very important, kena train.
Disiplin.
Yes. Kena disiplin, train your mind untuk jaga makan sikit dengan kerap. And sebelum kenyang dah berhenti makan, ikut sunnah Rasulullah. And juga exercise lah. Itu yang paling penting sekali. And of course, untuk siapa-siapa yang tak berjaya juga, orang yang terlampau besar yang mana we feel that obat dengan balloon tak efektif, then of course the next step is the gold standard for weight loss treatment, undoubtedly bariatric surgery.
Okay.
So patient tanya, apa tu bariatric surgery? Kenapa nama pelik tu, doktor? Sebab in medical terms we use a lot of Latin words or Greek word. So baros, which is bariatric, in Greek means weight. So it's surgery for weight loss. But now kita dah synonymouskan dengan metabolic surgery sekali. So sekarang kita panggil bariatric metabolic surgery. So apakah itu metabolic surgery? Operation yang sama, tapi tujuan utama adalah untuk mengurangkan atau resolve diabetes. Okay, bariatric surgery is more, tujuan utama, primary outcome measure is for weight loss. Secondary outcome measure is hopefully all the comorbidities get better. So if you see the difference, benda yang sama, kegunaan dia berbeza sedikit. So metabolic surgery selalu kita buat BMI yang rendah sikit. So BMI yang tak tinggi sangat, tapi sebab diabetes dia teruk.
I see.
Yeah, so we have patients been referred by endocrinologists sebab been on high dose insulin, HbA1c berbelas-belas. So obviously it's not effective. Then sebab itu mereka perlu the most effective treatment lah.
Gold standard.
Yes. And apa saya cakap ni is saya echo atau saya cakap based on clinical evidence. So dah beribu-ribu dah research dah dibuat untuk buktikan yang the effectiveness of bariatric surgery, the safety of bariatric surgery in improving people's quality of life, people's health, everything. In fact, saya di UKM banyak buat research dan publish a lot of paper looking at improvement in komplikasi of obesity dari head to toe, including sexual dysfunction, male and female issues, looking at psychological aspect, on top of improvement in diabetes, high blood pressure, cholesterol, kita punya kidney function improve, kita punya jantung improve. So banyak berpuluh-puluh paper already.
Have you come across, Prof, macam you mentioned earlier, ada isu di mana pesakit BMI biasa ambil ubat. Ada ke isu pesakit BMI biasa pergi balloon, requested for balloon? I want this. Ada juga.
I mean, because first is we cannot reject them terus. Sebab very important that everybody needs a proper explanation. Because if we sebagai health profession kita reject terus, saya BMI normal doktor, saya nak buat balloon lah, and I jawab tak boleh lah, dah jangan kejar saya. That is very for me as a doctor, which our job is to not only treat people yang ada masalah penyakit, tetapi to educate people yang tak ada masalah penyakit supaya they don't get penyakit. Then we are not holding our responsibility right lah. So saya tak discriminate mana-mana orang yang tanya soalan, and untuk pendengar ni, mana-mana soalan, tak ada soalan, satu soalan pun yang soalan bodoh. Semua soalan adalah soalan cerdik. And saya terima kasih kepada sesiapa yang bertanya soalan, sebab orang yang tanya soalan tu, of course, sebab dia nak meningkat lagi pengetahuan mereka. So kita punya responsibility untuk menjawab soalan tu. So kalau orang BMI normal nak buat balloon, dan saya kata, okay, first is apakah itu balloon? Apakah fungsi balloon? Nombor 3 is siapa yang sesuai untuk balloon? So maaf puan tak memenuhi syarat untuk buat balloon, sebab it will be, if you puan buat juga, it will be off label. Okay, now of course if puan buat, puan tak boleh expect penurunan berat badan sebanyak orang yang obese. You cannot compare between apple and pear. You have to compare between apple and apple. And lagi pun sebab ramai yang tak besar, tak memenuhi syarat, nak buat bariatric surgery supaya dia tak gemuk. So I cakap macam ni. So bariatric surgery atau balloon, mana-mana kaedah obat pun ada side effect. And bila ada side effect, it adds risk. So kalau you tak ada masalah, yang mana you boleh just diet and exercise, kenapa you nak tambahkan risiko? Okay, lainlah dengan seseorang yang memang perlu bariatric surgery, sebab dengan obesity, kencing manis tanpa kawalan, mereka memang perlu buat rawatan, perlu melalui operation. Jika tak buat operation, the risk outweigh the benefit. Walhal jika you buat operation, the benefit of the operation outweighs the risk. Of course, mana-mana operation ada risk. And bagaimana kita nak kurangkan risiko, Sebab itu kita buat pre-op assessment dahulu to make sure that patient ni betul-betul memenuhi, patient ni betul-betul faham nak buat operation, patient betul-betul kalau kita suspect ada psychological issue, kita akan refer to either psychiatrist or psychologist untuk make sure that the mental state is betul-betul prepared untuk rawatan ini. Sebab walaupun the paling short sekali balloon 4 bulan, you buat on somebody yang ada eating disorder, after 2 days, dia menyesal lah, saya suka makan. You know, in these people, you cannot force them to go for rawatan obesity walaupun mereka obese. You know, maybe you have to find another way to make them lose weight, because either they say, saya nak keluarkan balloon, you wasted already your money. Nombor satu, you wasted other opportunity for other people to buat if we do it in the public. OT list ke. So this is why you know, how kita pilih patient, select patient has to be very specific and detailed, and has to be very methodological. That means systematic.
Okay. You mentioned earlier about bariatric surgery as the pinnacle of metabolic disorder, diseases ataupun obesity. Can you walk through the evolution of bariatric surgery from the early days sampai sekarang?
So basically, the first bariatric surgery was actually the prototype lah. The prototype of the operation was introduced in the early 60s. So over time it has evolutionized and revolutionized. So if you look at the old type of operation, they are very extreme type of operation. They did a bypass operation yang terlalu panjang, di mana common channel, yang mana that channel of intestine untuk penyerapan nutrisi is too short. So because of that, patient get severe malnutrition and people die. And apatah lagi operation masa dulu, zaman dulu, operation dibuat open. That mean open operation, that mean potong, the scar is long. So imagine, dah lah orang tu besar, operation besar, so recovery is poor, and most people get lung infection, pulmonary embolism. Masa tu tak adalah anti-DVT prophylaxis semua. So the risk is very high. Tapi over time, and this is why how science progress is, one is the findings of new innovation atau treatment. Then you can prove that innovation too is workable, suitable for human being, and efficient, but the most important thing is safe. So that's why trial ada fasa 1, 2, 3, 4. Okay, bukan senang nak release one treatment ataupun modality. So over time, new type of operation was identified, and the sole purpose is to get the most efficient but the least complication or complicated type of operation. Until so sampai now in the year 2024, kita ada banyak jenis type of operation, tapi senang nak ingat, kita bagikan kepada beberapa kategori. So bagi saya ada 3 jenis kategori. Kategori pertama is non-bypass type of operation.
Non-bypass.
And then you have the bypass. The bypass bagi pada 2 types. Okay. So the non-bypass, aim utama is nak kecilkan perut saja. So the commonest type of operation is nama dia sleeve gastrectomy. Okay. So it's done laparoscopically. With sleeve gastrectomy, kita nak kecilkan perut by removing 70% tinggal 30%. So it look like a banana shape. So it restrict the volume. So it reduce the calorie intake. So you lose weight from there. Okay, and create a consistency environment. So this operation takes around 1 jam.
1 hour
to 1.5 jam, depends on the size of the patient. Hospital stay from my side lah, I'm not talking about other doctors, 2 hari 1 malam di hospital. Okay. And then in terms of berapa banyak dia boleh hilang, excess weight loss. How much excess weight loss? About 70% on average.
Wow.
So katakan orang tu 160 kilo berat, tinggi 160 cm, so dia overweight by 100 kilo, so potentially can lose about 70 kilos, 70 kilo. Tapi bila kita cerita pasal weight loss, long term, apakah risiko untuk berat naik balik? So in sleeve gastrectomy, the problem is dia akan restrict the amount of food so tak boleh makan banyak, tapi you boleh curi makan benda manis.
Ah.
So the chance of weight regain after sleep kalau seseorang itu tak disiplin is greater than the bypass type of operation. Tapi kalau you look at numerous literature review, the first 5 years more or less comparable. In terms of side effects, sleeve GERD, acid reflux. Okay, if you tak ada acid reflux sebelum operation, dalam 5 ke 25% can get acid reflux. Okay?
But you already removed 70%. How come the acid can reflux?
Yeah, because when you cut the top part, you divide the oblique muscle sling, which is one third forms the lower esophagus sphincter. So you loosen it. Plus kat bawah ada pylorus. So bawah ketat, atas longgar, ikut mana naik ke atas. Plus when you make the stomach narrow, ikut physics, lagi the narrow the diameter, lagi the increase the internal pressure.
Okay.
Yeah. But of course, obesity is one of the risk factor of GERD. So most people notice that as they lose weight, walaupun the side effect is GERD, the GERD get better because patient lose weight. Okay. So tapi kalau patient tu ada GERD yang teruk, so that means dia memang sebelum operation lagi dah ada pedih hulu hati dan terpaksa bergantung pada ubat, then the better operation would be gastric bypass.
Okay.
So that's why ada banyak jenis. So apa beza bypass dengan sleeve? So sleeve is basically you just remove 70% of the stomach. Bypass tak buang apa-apa. So obviously it can be reversed in the future. So it's just a bit of modification and plumbing. So you create a small pouch of the stomach and you join that stomach to the small intestine. It depends on different types of operation. Ada banyak jenis bypass. Okay. So the weight loss can be between 80 ke 90% excess weight.
For the bypass surgery.
And in terms of chance of weight regain is much lesser than sleeve. Okay. But the typical side effect is because you join perut to usus kecil, perut mengeluarkan asid, so usus kecil tak biasa dengan asid. So the risk of ulcer is there, but increase in patient yang smoke, patient on steroid, and patient on painkillers like Brufen, Acoxia, and Celebrex. Okay. Nombor 2 is dumping syndrome. So phenomena where you makan, food dump terus ke usus kecil, so you get hypo episode. Because sudden increase in insulin, because sudden absorption of glucose. These can be modified by diet control. And last kali, nutritional deficiency. And we talk about the bariatric surgery, tak kira whether you buat sleeve ke bypass, the typical vitamin atau mineral yang tend to go down sedikit selepas bariatric surgery adalah iron, B12, folic acid, calcium, zinc, magnesium, and phosphate. So this is why we recommend patient ambil multivitamins.
And the vitamins reduction is both for sleeve and also bypass?
Same.
Oh, the same.
Yeah, because for sleeve you eat less. Okay, absorption the same because it doesn't affect the small intestine. And excretion faster because the small sleeve increases internal pressure, so the gastric emptying is faster. Okay. So it doesn't allow enough time for the
absorption.
Absorption. I would say intrinsic factor from the stomach, or acid is very important for oxidization of iron. So that it can be in a form where it's much easier to be absorbed in the proximal, distal duodenum and proximal jejunum. So untuk bypass small volume, you intake less.
Yes.
And then penyerapan pun kurang. And outflow cepat sikit because of the transit time. Because in the bypass you shorten the functional part of the small intestine. Okay. So then we became buat sleeve reflux, takut weight regain balik. Nak buat bypass, nutrition, dumping, and ulcer. So is there any type of operation that can have the both best of sleeve
outcomes
and bypass? So there is a new procedure coming up. It's called sleeve plus procedure. So you buat sleeve. So sleeve cannot have dumping lah because you have the pylorus.
Yes.
The plus when you buat bypass, tapi proximal jejunal you bypass. So that means you leave the proximal jejunum intact, so the food can still lalu kat proximal jejunum. So you still have that absorption. And the bypass is because in the middle part, is joined between jejunum and jejunum, not stomach and the jejunum. So no ulcer.
Yes.
Yeah.
So this thing
So
is
this is the new
ongoing,
one. Yeah.
available in HCTM.
Yeah, I do them. I do them in UKM. Yeah.
Oh, okay. And laparoscopically also?
All laparoscopic.
All laparoscopically?
Yeah. Soon we are hoping to get robots as well.
Oh.
Yeah.
And how do you decide between sleeve bypass and this sleeve plus?
So ada banyak factor that we look at lah. Their weight, their comorbidities, reflux, presence of reflux, any family history, cara pemakanan. Kalau dia suka makan banyak tapi tak makan manis, sleeve cukup dah, kecilkan perut. Kalau dia suka makan manis, tak makan banyak, mancing all the time, tengok TV non-stop and malas nak exercise, you better buat bypass, takut sleeve tak cukup.
Okay.
And then kalau patient besar sangat, 200 kilo, buat sleeve, dia hilang 40 kilo tapi still 160 kilo. That's why better bypass.
Okay.
Tapi at the end of the day, it's important for you to acknowledge all these things to the patient. At the end of the day, the patient has to decide lah, eventually which one they would opt for.
So it's not like surgeon's preference. It's more towards the personalization treatment for the patient, right?
I mean, certain things, we have to take control lah. We have to decide and for the best of the patient. But in the majority, it has to be a reciprocal, decision.
But whatever it is, you still have to reduce your sweet intake, your gula, betul tak?
Yeah, as I said from the start, the principle of weight loss is calorie deficit. If you don't exercise, you have to up your reduction in calorie intake. And calorie comes from where? Carbohydrate.
Yep.
Yeah. So the principle, if you cut down carbohydrate, the body needs energy. The substrate for energy is calorie, which is carbohydrate. So if you cannot get carbohydrate, you have to use the carbohydrate which is stored in the body in the form of fat or glycogen. So by the process of glucogenolysis and gluconeogenesis, then you burn the fat to produce energy. That's how you lose fat. Yeah.
Okay, you mentioned recovery rate 2 days post surgery. Is that similar for sleeve and also bypass?
Recovery rate. Recovery rate is more or less the same. The bypass, I tend to keep them an extra day, just for observation.
Okay.
Yeah.
So, any common side effect that you notice? Besides you mentioned dumping, those things, dumping.
Yeah. So bila kita cakap pasal I say risk, we divide into two things: complication and side effects. So both are two different things. Side effects adalah something yang you expect to get and kena accept lah if you get that. So contohnya seperti kalau buat bypass, ulcer, dumping potentially can happen, or nutritional deficiency. So you have to do something to reduce it lah. So ambil anti-acid medication, stop smoking, dumping, makan sikit kerap, jangan makan terlalu banyak, elakkan benda manis. Kalau nutrition, you can take more protein, energy food and supplement like vitamins. Sleeve, makan sikit dan kerap, jangan minum dengan makan sekaligus. So it reduces the risk of reflux. Whereas complication is something yang kita tak expect but can happen, and if it happen, patient has to accept it. The most important thing, we have to catch it early so we can treat it early, and the earlier we treat, the better. So contohnya selepas operation, patient demam, pulse rate 120, okay, BP normal. So I wouldn't wait and just tak apalah, kita bagi tengok dulu lah esok. I akan terus buat CT scan to make sure tak ada bocor. Because if ada bocor, then ada banyak option. You can do endoscopically, you can you have to go back in, you can put stent. So ada banyak option, depends on the type of leak. Because if you leave it 3 days, then by then lagi bahaya, as opposed to catch early. Okay. So these are the typical complication. Other complication macam bleeding.
The one missing.
Normally kita, sebab nowadays the instrument is very advanced, so very rare get bleeding, but occasionally you can get. So that's why again monitoring. So pulse rate tinggi, BP start dropping until proven otherwise, it has to be related to surgery. You just go back in atau buat CT scan lah, and stop the bleeding. Macam narrowing ke susah sikit sebab sekarang kita pakai calibration tube, so kita akan cut ikut size calibration, so the chance untuk terlalu narrow is small.
Less.
Yes.
Okay, how about anastomotic leak? Last time people talk about anastomosis leak is something that really not to say common, tapi troublesome.
Yeah.
With the advancement of technology, is it getting lesser?
Bariatric surgery ni sebenarnya a very safe operation because kita buat assessment sebelum operation from head to toe. Orang tu ada diabetes kena control dulu, orang tu on blood thinning medication kena stop dulu sebelum buat, bukan-bukannya buat. Plus the technology and the screening yang kita buat untuk make sure tak ada bocor, seperti kita inject dye warna biru, fill up with air of the new stomach at a higher pressure before we complete the operation. That again reduce the rate of leak. I mean, you cannot avoid leak. Any operation ada risiko leak, tetapi the risk is definitely less than 1%.
Okay.
Very, very rare nowadays. Yeah.
Where you currently practice, Prof?
So I'm at primarily dekat HUKM, Hospital Chancellor Tuan Mukhlis. That's my kerja hakiki lah. Yeah, so saya ni pegawai kerajaan. Tapi kita buat sessional work outside as well.
And outside in
Like Gleneagles.
Gleneagles.
Yeah, and KPG Abah Puteri. And occasionally I go and put balloons at Masa Avenue Specialist. Yeah. Based on demands. Yeah. But also to at the same time we teach there as well. Yeah. So it's a win-win situation lah. But so, the majority of my time is at UKM lah. So you only do all these sessional work out of hours, weekend.
So throughout your career, any particular cases that really you remember forever?
Difficult lah, because actually interesting because my daughter pun tanya soalan macam tu. In the past maybe yes, but now because you deal with complex operation, nothing actually excites you anymore. Yeah, because you deal with so much complex operation, and like HUKM is one of the center where get a lot of referral with complex stuff. So I mean, you know, at the end of the day, you know, the more experienced you are, of course, you will encounter, you know, interesting cases, complex cases. But for me, I just take it one at a time, focus, solve the problem. That's the principle. Yeah, you cannot be, you know, feel challenged with a case. You know, the point is, if something like you buat operation and it's too challenging for you, means that you select the wrong patient already. You shouldn't be operating on that patient, because operation should be smooth and straightforward. If you choose the right patient. Okay, I'm talking about elective case lah. Emergency is different thing, and even emergency pun. This is why most macam polytrauma ke, you tak boleh deal alone, because other aspect of the human body pun impacted kan. So it has to be in combination with other specialists. Barulah success. Tetapi answer to your case is, at now you know, every single case is interesting for me, and tak ada, I cannot think, because we deal with so many complex case. So I cannot come in my mind sebab dah so get used to it. So nothing actually overwhelm me now.
So back towards your early days before you decided to enroll in bariatric surgery as a career. What influenced you at that time?
Oh no, I always wanted to be a surgeon.
Okay.
I always wanted to be a surgeon, and initially I was interested with orthopedics. Tapi the problem is orthopedic use a lot of X-ray.
Okay.
You know. So I thought, you know, so banyak X-ray guna lah. Everything X-ray. So you never know the risk of long-term X-ray.
Yes.
Even though
radiation,
you cover in your chest, but how frequent you cover your head doesn't cover your arms, doesn't cover your feet. Okay. So I decided, no, I want something which is non-X-rayable. Hence general surgery lah. And I like something which is very practical. So things that you can see patient in clinic, you can do endoscopy, you can do robotic work, you can do laparoscopic, you can do open operation. So for me, I like simplicity. You have a lump, take it out. Yeah.
So you were trained back in overseas, right, Prof?
Yes, correct.
And then before you completed all the training, then you joined UKM.
Yes, correct.
As a professor in upper GI
Yeah.
surgery.
Yeah.
Okay, I just want to ask your point of view on certain facts or myth. Then maybe we can discuss about it. People says some surgeon might face skepticism about bariatric surgery as a shortcut rather than legitimate medical intervention. Is it?
That perception may be around 10 years, 20 years ago. Not now.
Not now.
Not now. 100% I can tell you is not now. Because I've been invited to many conferences which is non-bariatric surgery or surgical related. And they accept that that bariatric surgery is one of the important modality. Otherwise, why would it be incorporated in clinical practice guideline for diabetes? Why would it be incorporated in the clinical guidelines for obesity treatment?
Yep. And then do people treat, I'm talking about patients, do they treat bariatric as aesthetic surgery nowadays?
Well, WHO has defined obesity as a disease. So,
it's no longer
when we treat obesity, we're treating a disease. That's answer it.
Yep.
That answer it.
Yep.
Betul tak, pendengar? Or penglihat saya? Yes.
Okay, we know that to combat obesity in Malaysia is challenging, knowing the fact that the food is a challenge, number one. Number two, sedentary lifestyle. Number three, the rate of kedai makan mushrooming like nobody's business.
Yes.
So if let's say you have the power to implement one policy to combat obesity, what would it be?
Basically, at the end of the day, everybody has the right to blame here, there, everywhere. But at the end of the day, my advice is just look in the mirror and you have to sort yourself out based on what you are at that point of time. If you're fit and healthy, stay healthy. If you're not healthy, if you get help. If you're obese, get help. So I cannot fault anything else outside. They have the right to mushroom. They have the right to do whatever they want. It's the individual that matters. So a lot of patients ask me, Doktor, tolong buat operation yang paling power sekali untuk saya. I tell them, what makes the operation powerful is you. Yeah. So don't blame other people. Blame yourself.
Don't blame the external factor.
Yes,
it's all about the
exactly.
intrinsic.
Yeah.
So it's wonderful to have you, Prof, for our session. I would like to thank you for your time and your sharing and for your valuable insight.
My pleasure.
Okay, maybe one day we invite you again.
Of course. I'm still pumped up. I can still go for another 4 hours. No problem.
Okay, thank you, Prof.
All right. My pleasure.